This is basically a continuation of the lecture I gave this morning. The good news is that it's much easier to comprehend and is more easy than the previous one in the sense that we have a much clearer picture of the pathology and how the disease presents, what are the problems that are associated with the development of it, and the treatment. So as you can see, the name is ICANS, or immune effector cells-associated neurotoxicity syndrome. I don't have any conflicts of interest. And again, I want to start by saying that in the last 15 years, the management of cancer has completely changed. And we have gone from drugs that were extremely toxic, chemotherapies that brought patients to the ICU in multi-organ failure, to medications that can be actually given in the clinics, and the patients don't see the hospitals these days. Most of the patients that we receive in the ICU more recently are two extremes. Patients that are basically in stage 4, that are in phase 1 therapies, that are extremely sick in multi-organ failure and terminal. And those patients that present because they have some kind of adverse effect of one of the immunotherapies. These are an array of immunotherapies that are being used these days. And one of the most important are the immune effector cells therapies. In this particular case, the CAR T cells. As I mentioned earlier today, this is only a therapy that started 30 years ago, first in the lab. It was not effective. 10 years later, was already been effective in the second and beginning of the third type of CAR T cells. And we are now in the 4th line using therapies that are extremely effective. Unfortunately, as we already know, these therapies are all associated with a very high number of adverse effects. And the reason is that you are injecting in the body T cells that are extremely aggressive against the tumor cells that they are being prepared to target and destroy. So you have here an array of different CAR T cells and genetic modifications, and each one of them is extremely complicated. Really, you have to be an expert in the field to deal with them. But this is a very simple graph that follows what we were talking about this morning about macrophage activation syndrome. So here you have a patient gives blood, you take the blood, identify the T cells, return the rest of the blood, you modify the T cells, you culture them after the modification with a chimeric antigen, grow them, grow them, grow them. When you have enough, then you prepare the patient, and here you have it. You do the conditioning regimen, and then you give the cells. Once you give the cells, boom, the cytokine storm. So here you have your cytokine storm, and superimposed comes the neurotoxicity. This is the number of CAR T cells that are available in the periphery. This is 28 days. And here you have the phases. These are a multi-phase cytokine release type of pattern. You can see here initial IL-2, IL-7, and IL-15, followed by IL-1B, IL-1RI, and GM-CSF. And immediately after that, IL-6, IL-8, IL-10, interferon gamma, and tumor necrosis factor. Very simple, all your phases, and you see how the process appears. Then, as we discussed this morning with the macrophage activation syndrome, you have the T cells that arrive, the interaction with the tumor cell releases all the cytokines that are going to produce the inflammatory response You have IL-6, IL-1, nitric oxide, etc. And of course, it affects the endothelium, there is vascular leakage, and then you have hypotension, and you have fever, etc. A process that we already know. So the simplification of the process has reached this point. We now can classify CRS in this way: grade 1, 2, 3, and 4, with 3 simple things: temperature, blood pressure, and hypoxemia. So then you have, when you have fever, grade 1. If you have need for low flow nasal cannula, you reach it grade 2. If you require vasopressor, you are already in grade 3. If you are requiring high flow nasal cannula, you are in grade 3. Those patients, grade 3 and above, in all the toxicities, go to the ICU. Grade 4, you may require multiple vasopressors, positive pressure ventilation, you may need to be intubated, etc. So how do you manage it? It's very simple as well. This is all protocolized, and patients respond very well, unless they develop HLH. So here you have the grade 1, the supportive care, grade 2, then you consider what to do here. If the patient is showing signs of inflammation that are significant, you can give him a tocilizumab or ciltuzumab, and this is an anti-IL-6. This is an antibody against the cytokine. If it's grade 3, you can continue or repeat it, or add corticosteroids, methylprednisolone or dexamethasone, whatever you want. In the protocol, we start with dexamethasone, and we follow later on with methylprednisolone if the patient gets sicker. And here you have it, the continuation. Some patients may need an anti-IL-1 treatment. So the definition of ICANS is simple. It's a neurological syndrome that can occur in days or weeks following the administration of the T-cell engaging therapies. The incidence, pay attention how frequent this is, 20 to 70% of all patients treated with CAR T cells. That's the importance for you to be aware of the syndrome if in your institution are using CAR T cells. And I imagine that if you have CAR T cells being used in the hospital, you already have seen this syndrome. I don't know how many of you have been exposed to it, but it's a very simple syndrome to recognize and deal with, unless the patients get into this group of 13%, which are very severe, develop brain edema, status epilepticus, and the management of this patient is extremely difficult. The risk increase in certain therapies, like blinatumomab, 65% of the patients develop the syndrome. The risk factors, if the patient have a previous neurological impairment, the age, the older they are, and other types of lymphodepletion therapies. As I mentioned also this morning, the ones that we use in the United States, or particularly in my hospital, Kymria and Yescarta, to use these medications or to take care of patients that receive this type of drugs, it's gonna call it drugs, you have to be certified. So you have to take a course dealing with all the process of how these things are developed, what are the symptoms, what are the, how is the management, et cetera, and pass an exam at the end. So you can't be allowed to take care of patients in this particular group. And the Yescarta has many more symptoms and signs of neurological impairment when you use it, as you can see here. These patients can develop tremor, ataxia, seizures. These patients have more consciousness disorders. And here you can have even paranoia, stupor, etc. So the pathophysiology of ICANS, again, follows the MAS and CRS physiopathology. Basically, you inject or infuse the CAR T cells. You have circulating monocytes, cytokines, and disruption of the blood-brain barrier. At the level of the tumor cells, you have also liberation of the cytokines and all the reaction that we already discussed before. And in after you have the disruption of the blood-brain barrier, you have a recruitment of CAR T cells sometimes, and the inflammatory responses associated with it. So these are the different points where you can act, okay? So as we said before, you have the CAR T cells that are the immune effector cells, the tumor cell, the interaction leads to all these cytokines releases. So you can have the first cytokine here blocked by lencilimab. If it's IL-6, you can block them with tocilizumab. If you have IL-1, so anakinra. If you have TNF, you can use any of these, etanercept, and catecholamines, you can use metirosan. These are the markers. The markers are, as we mentioned before, all the cytokines, ferritin, and other markers like thrombocytopenia and LDH that identify severity of illness. The lower the platelet count, the higher the lactate dehydrogenase, the worse the outcomes, especially in patients with HLH or patients with a very severe inflammatory responses. The circulatory changes, DIC, endothelial activation markers, electroencephalographic changes, diffuse the theta delta slowing, and CT MRIs are usually negative, but if are not, well, that's very concerning. In all our telephones in the hospital, we have this app, it's a CARTOX app, and then we have the toxicity grading, the toxicity management, and management of antibiotics. So I don't even take tables or anything like that. I go with my telephone to the patient, open the app, and immediately start to ask the patient questions and add, the score here. And then with the score, I come and use it in the table that is here. Okay. So this is a paper that was published in 2019. Is the consensus grading for cytokine release syndrome and ICANS. You can go over it. All these details are probably there. And there are a lot of different grading systems that exist. We are not going to go over them. I just want to show you how wild this is. How many centers have all these grading systems, despite that we have a very simple way to actually classify these patients and manage the patients in our hospital. The ones that I show you are the ones that we use. So here you have all these. Even Sloan Kettering has its own CARTOX criteria. UPenn also has its own criteria, etc. Okay, so how do you grade ICANS? It's also relatively simple, as long as you have your table and score the patient right. So if the patient has an ICE score of 7 to 9, it's a grade 1. If the patient has more and more deficits, for example, cannot count backwards, cannot name the objects that you show him. You show him a pen, what is this? Or you show him a telephone and he cannot identify it, the score continues to drop. No? If the patient is unconscious and is not responsive at all, well, the score is even worse. So like the patient is not arousable, the patient is a grade 4. If the patient has a seizure, already enters in the grade 3. If the seizure is more than 5 minutes, then it's a grade 4. Okay? It's very simple to grade. All the patients grade 3 go to the ICU. There are hospitals that admit the patients in grade 1 or grade 2. That is a good idea when you are starting these therapies in your hospital, because at the very beginning, when people are kind of calibrating the management of these patients, is very dangerous. And usually all these deaths that have been reported have happened at the very beginning of the introduction of the therapies in the hospital. This is very closely monitored in the United States. And if you have a death in your hospital, you can get all the programs shut down. So everyone is super scared when they are managing these patients. So here is a simplification of the previous table. And this is a study published recently showing you what are the most frequent things associated with ICANS. This is 23 observational studies, 10 prospective, 11 retrospective, and 1 mix. And when they identifies what type of patients develop ICANS. Well, diffuse large B-cell lymphoma, non-Hodgkin lymphoma, acute lymphoblastic leukemia, and chronic lymphocytic leukemia. Of course, they are the ones that are going to develop the syndrome because they are the ones that are getting the CAR T cells. So here you have ICANS onset was more frequently associated with presence and severity of cytokine release syndrome. So the more severe the CRS is, the higher the chance of developing ICANS. The most frequent neurological sign was aphasia. As I mentioned before, they cannot recognize the relatives. If it's a gentleman married, they cannot recognize his wife. Sometimes they develop delirium and think that the nurse is going to kill them, things like that. The MRIs and CTs, as I mentioned before, usually negative. One of the signs that you can find is just cerebral edema. Electroencephalogram in general, diffuse general background slowing. It appears about 6 to 7 days after the injection or infusion of the CAR T cells. And the mortality associated is relatively low. It's about 2 to 3%. Some patients still have neurocognitive complaints 1 year after. So in the CARTEX, these are the things that we actually assess for neurologically: orientation, ability to name objects, following commands, writing. It's amazing how the patients can be writing perfectly well, and a few hours later, they just basically, you ask them to write a name or a sentence, and it's just basically nonsense. They start to scratch things in the paper. So management considerations. Grade 1, the most important thing is to be following these patients very frequently. So the clinical aspect of it is very important. So to examine the patients frequently and well, and being consistent with the exam. I imagine that you have had the experience that a nurse comes and the patient has a Glasgow Coma of 10, and then comes the next nurse and the Glasgow Coma score was 6, for example. So there are discrepancies in evaluation of patients from the neurological point of view that can be very dangerous. Once a patient starts to develop signs of any neurological impairment, we usually start an anticonvulsivant. We use Keppra. We rule out all other reasons for encephalopathy and maintain a close monitoring for progression. Once the patient is in a grade 2, again, the patient continue with the frequent neurological evaluations. Neurology gets involved. The patient gets an MRI, no? Of course. If there is a neurologist, the patient needs an MRI. Certain centers don't run so fast to do it. We actually do it because we want to be sure that we don't miss anything. Again, if you didn't start in grade 1 neurological anti-seizure prophylaxis, you start anti-seizure prophylaxis. Sometimes they consider to start a lumbar puncture in case the patient has an infection, and consider steroids if symptoms are persistent. Grade 3, the patient gets transferred to the ICU. The neurological examination is Q-hour, and we look for signs of elevated intracranial pressure. We continue monitoring, doing frequent neuroimaging, CT or MRIs, electroencephalograms daily, and continue to treat for seizures. If the patient has seizures, increase the dose. This neurosurgical consultation, I don't know where they come from. We don't consult neurosurgery. What are they going to do with the patient unless there is something that they need to act, like putting an EVD, for example. Some of the patients require an EVD if they have signs of cerebral edema or intracranial hypertension. So that will be the only reason to consult the neurosurgeons. And then steroids, dexamethasone 10 milligrams Q6 hours. You can switch to methylprednisolone if you want. Then in the grade 4, supportive care again, neurological management as we actually were doing, management of cerebral edema, management of status epilepticus, if probably that's what the patient has. You consider other causes for encephalopathy, neurosurgical consultation here, probably for EVD placement, and then high dose steroids and anakinra, an anti-L1. So this is from the guidelines that I showed you before, the 2019 guidelines. Basically, the only difference with what I told you is that they classify these groups in two. Whether you have CRS or you don't have CRS at the same time that you have ICANS. If you have CRS with ICANS, then they use an anti-IL-6 monoclonal antibody, okay? Which basically is a standard. So if you have, for example, with concurrent CRS or cytokine release syndrome, then you use tocilizumab. And that's basically the management. So this is a study that we did in the United States, 11 centers that actually are doing CAR T cells in the United States. And we wanted to see what are their practices. This study was led by Cristina Gutierrez, which is from here, from Bogota, and works with me in MD Anderson. And basically, what we noticed here, for example, that some centers admitted patients with grade 1. As I mentioned, these usually are centers that are starting with these things. Most centers, 10 centers admitted the patients only when the patients were in grade 3. Some centers admitted when the patients were in grade 2, which is not a bad idea, especially if it's a weekend coming or it's in the afternoon and you don't want to leave a patient in the floor deteriorating. Let's gonna say that you have a patient that is grade 1 and in the afternoon is grade 2, you don't leave that patient in the floor. My advice is take that patient to ICU and then continue monitoring the patient every hour. Because if you miss something in the evening, that patient can go rapidly to a grade 4 and die in the floor, and you miss an opportunity to save a patient that is salvageable. Okay. What else we found? We look at what they were doing in treatment-wise, and some centers actually use suicide genes. What is a suicide gene? If you have CAR T cells and the patient develops CRS and the patient develops severe ICANS and the patient gets intubated and is not responding to anything, remains in status epilepticus, you're going to lose the patient. You kill the CAR T cells. You just inject the gene to kill them off. So the mortality, as I mentioned, this is the study that described the mortality in 23 studies, about 3% mortality. So to summarize, this is one of those phenomena that happen as a result of the immune effector therapy. Things are going to continue to progress. Most of the researchers in this field are just focused in the reduction of the toxicity, of the collateral damage of the immune effector cells. Recently, we have a World Congress of Oncology Critical Care, and the Nobel Prize of Medicine in 2018 gave a lecture about it, and I had the opportunity to talk to him, and he said that was 24/7 the job of all the guys that have developed these therapies, and that eventually we were going to have therapies that were almost free of adverse events. In the meantime, what we need to do is remain alert, learn a little bit about it. As I told you earlier, you need to refresh your immunology. I think that as we have seen, has been kind of a pattern of definitions and therapies and lack of a very good picture of what you have in front of you because the costs are too high. If you want to do panels like I show you, you want to look at every single phase and what is the cytokine that you want to target. If you want to target the IL-6 or IL-1, you want to know which one is higher, which is the one that is causing the inflammatory response or the problem. And is very difficult because not all the centers have that capability. I have still 5 minutes, but I think I will stop here. Thank you very much.